See, and that's what I read.
Maybe not a single, but a single standard, right?
Payer.
A single standard we've talked about.
A single standard is fine. The advantage of a multiple payer is that nobody dares get too high in cost because they'll lose business to those who have a more modest charge for their insurance.
Well, that hasn't happened in our country.
Yeah.
And it's not clear to me that that's a clear advantage, but we may have a hard time getting single payer in the platform, but we need to have a single standard and economically.
Maybe what Obama is talking about, that we need to break up these monopolies. Okay, if they cannot agree with each other to do monopoly pricing, maybe that way, if we have like smaller providers, I don't know.
Well, many of the pharmaceutical companies have us by the throat because one owns the patent for some medication that is really very helpful, and we have no idea what it costs to produce it.
I have a chart there that shows you that the United States is the highest user of new drugs off the shelf, and that's very expensive. So other countries are doing maybe as much medication as we do, but they do cheap.
It's called the Willie Sutton syndrome. Willie Sutton was asked, why do you rob banks? And he said, that's where the money is. Why do they charge so much in the U.S.? That's where the money is. Others have somehow been able to, perhaps as government, control those costs by saying, no, we're not going to pay for that. We're going to give you this much. And that's it. And I'm fully aware that the Canadian government charges their recipients of a prescription far less than it costs in the pharmacy in the U.S. And I don't quite understand that double standard. And then I go to Guatemala and see the disparities of medication there versus what people can afford. It's even more outrageous.
I'd like to see us reduce disparities. I mean, I think that probably every one of us in this room is on the well taken care of end. Here. Okay? Yeah. All right. Either we've pieced, right. We pieced together enough money to be able to do that, or we're in a place where healthcare is very high. But disparities just exist. Gender, most of them are related to poverty. Gender disparities, racial and ethnic disparities, rural and urban disparities. But we have to take a look at the data and begin to reduce the disparities.
Absolutely.
Healthcare standards across the board.
Yeah. We can't reform the healthcare system without addressing equity and issues in healthcare.
Now, I can give a single standard example. It's one that I know well. We had a huge outbreak of measles here in the Milwaukee area in the 1990s. Were you here?
No, but I was part of the Cleveland outbreak.
Okay. And at that time, they were happening all across the United States, and at that time it was discovered that it was disproportionately affecting preschool children. Many of them from small or minority populations. Immigrant populations, racial and ethnic populations, high-density urban zip codes, rural areas, and that many children died. So 2 years later, the Congress and the federal government made the immunization of infants one of the highest health priorities in the nation, and it went to the professional organizations of physicians and set one immunization schedule. Okay, this happened in 1992. Okay, and Wisconsin took that to heart. We developed an immunization registry, which we opened to the public in 1999 and for public health. And then we began working with private providers, and we're working with all the private providers in southeastern Wisconsin. The most successful one was able to reduce its annual health care costs by over $1 million, to raise its rates from 50% of the children in the system, and this is over 1 million children in the system, immunized to that standard to across the board above 90% for the last 3 years using the electronic data, and partnering with local public and state public health agencies where people were not covered for vaccines to send them to the public health agencies and put all these records in one place accessible to everyone. and with the schools and the daycare systems. This is happening across the board here in Wisconsin, and our immunization rates are very high. We're probably in the top tier of states in the nation. But every state that is in the top tier, and you work very hard to maintain that, the same thing. The government set the standard. They began to put money into electronic data sharing. We began to do wide health education for providers and parents. We got non-traditional community partners and traditional community partners to do it, and got out there and worked the streets and continue to do that. We had measles here only a few months ago, got a lot of hype, you all saw it on the news, and we didn't have 1,000 cases and we didn't have anybody die. I probably talked to thousands of people on the phone, and we were using everyone we could beg, borrow, and steal to track some of these folks down that we thought were exposed and get them vaccinated. We vaccinated thousands more adults. We made people stay home, and we did everything, and we didn't get a dozen cases. I think the case count is only 8, okay, and it came in from a foreign country. So, you know, it does work. It still takes a lot of work. But there was a single standard, and the single standard is what everybody was looking for, and everybody knew it, and went to work again, as we do so often. So,
John, would you like to add something? The recommendation?
Well, this may seem a little self-serving because I am a primary care physician, but I think that the system has to invest in primary care. It has to incentivize people to go into primary care. Right now, the system, and this includes Medicare, so single payer will not change this problem, pays a specialist more to do the same work that a primary care physician does. And one of the reasons that that happens is because the people who decide what Medicare is going to pay, that board is dominated by specialists. And so something has to, in all of this, you know, who are the decision makers going to be about what gets covered, how the money gets spent, what people get paid for doing stuff? That process is just incredibly complicated, as we've seen with, you know, for instance, Medicare Part D, where what they came up with was a system where that's so complicated that nobody knows what their plan covers anymore. And nobody's plan covers everything they need, right? So there's a lot of epidemiologic evidence that investment in primary care results in better health outcomes than investment in specialists. But that is not at all reflected in the way that money is spent in the United States. And I think that not only includes primary care physicians, but also includes mid-level providers, as they're called, advanced practice nurses and physician assistants, having some, not just being used as cheap primary care providers, but actually paid what they're worth.
Yeah, and if I can just echo, it's our belief, and as I said, we have a number of allied organizations, that primary care providers are essential. A focus on primary care, we believe really strongly in the medical home model as a means of both improving quality and reducing costs. They are far and away the best resource if they're used correctly and supported correctly by public policy and payer system and all that. The best resource we have to prevent illness and to manage illness appropriately once there's a diagnosis.